before MRI scans, we really didn't have a good opportunity to see anatomically the lesions that were seen inside the brain and the spinal cord. With the advent of the MRI scan in the mid-'80s, we've been able to see that. So from a diagnostic point of view, it's revolutionized our capacity to see very early lesions in MS and to say that they are different from other causes of little white dots on brain scans. So much so that the diagnostic criteria for MS have changed dramatically over the course of the last 20 years and directly incorporate changes on MRI scans as a fundamental part of the diagnosis of MS. So much so that now many patients really do not undergo spinal fluid examinations, where in the past essentially 100% of people would be diagnosed only after a spinal fluid examination, which is of course an invasive procedure. So from a diagnostic point of view, it's revolutionized things in that we can very rapidly, more correctly, and less invasively make a diagnosis of multiple sclerosis.
In terms of management, once the diagnosis is established, when we put people on the newer disease-modifying drugs, which we know will reduce attack rates, reduce the amount of accumulated lesions that occur that can be seen on the MRI, if we're waiting for attacks to tell us that the drug may not be appropriate for that particular patient, we may do the patient a disservice. That's because we know that the frequency of subclinical new lesions, as seen on MRI, exceeds clinical attacks in untreated patients by a factor of about 10 to 1. So it's appropriate, increasingly, to look at MRIs on intervals, even in patients who are apparently doing well, to see whether, in fact, the subclinical activity is ongoing, and it's just the location of those lesions which have spared the patient a clearly observable episode of new neurologic disease.